There is a multiple episodes of tonic movement of all over movement, all limb and neck with a neck, and there is loss of consciousness and uprolling of eyes lasting for few seconds. It's not associated with bowel and bladder incontinence, and there is a post-ictal drowsiness. There is a coarse tremor noticed when she went to grab a bottle of water, and there is no anxieties while walking and sitting. She has a postprandial vomiting for 3 episodes over 3 days. There is no history of diarrhea, no history of abdominal pain. Initially, she was brought to the MS Bahayam since is seizure and followed by referred to CMC here. And past history, she had a bipolar disorder on regular medication, lithium sustained release 800 milligram OD and risperidone 2 mg OD. And it's a known case of diabetes mellitus for 3 years. She is on glimepiride 1 mg and metformin 1 mg. And then it's a known case of systemic hypertension for 1 month.
You're asking him for the diagnosis? Because it's the second case we're having, similar case. Okay. How many of you heard the first case by Kripa? You presented? No, by Tefila. I think most of you came late. What's your diagnosis? PGist. This is a very silent room. We had silent storm, silent something else. Now silent room. What do you think the nocturia is due to? Tefila already said something about that. Okay, go ahead.
Move on to examination. The pulse rate was that bradycardia and the BP was 110/80 and saturation was 94, respiratory was 24 and GCS was 14/15. Peripheral skin is warm, JVP not elevated, peripheral was felt, no goiter, no talavectus, clubbing, no cyanosis and lymphadenopathy. On CNS examination, she was initially drowsy and later higher mental function was become normal. And this is a normal cranial nerves and no motor deficits, and there is a decreased vibration on and joint position sense overfilled till ankle, and absent deep tendon reflex at ankles bilaterally, and there is no cerebellar signs. The CVS examination response to here no mover, and RS examination bilateral normal vesicular depth zone, and the per abdomen examination soft and liver palpable with normal span. What could be the differential for this presentation? Moving on to the symptom complex, and here the patient have CNS involvement with the cardiovascular involvement, CNS in the form of new onset of seizure and tremor and drowsiness, and CVS is the involvement of bradycardia and syncope. In view of there is a DD for it's may due to drug or metabolic or structural causes, and in this view of drug, and there is a acute lithium toxicity, and she has been taking a risperidone, so she can present with the risperidone with the serotonergic syndrome, and we can in serotonergic syndrome there is a hyperthermia and tachycardia. In lithium toxicity we have bradycardia, and since you have been hypertension, antenal causing bradycardia and cardiogenic syncope. And the metabolic and all the electrolytes are within normal limit. And the structural we rules of CT scan is within normal limit. On investigation, the total count was within normal with neutrophil predominant, and the sodium was 133 and chloride was 110 and potassium was 5.1 and bicarb was 20. The anion will be 3 millimole per liter, and the creat was 1.48 and lithium was 3.28 millimole per liter. This is a ECG showing there is a bradycardia with the narrow QRS complex, and there is no P wave in this. This is due to cardiotoxicity of the lithium.
What is the sodium?
Sodium 133. It's a case of severe acute and chronic lithium toxicity, then neurotoxicity in the form of drowsiness, seizure, and cold tremor, and the cardiotoxicity in the form of junctional bradycardia. You can see there is no P wave, there is a narrow QRS complex and bradycardia, and nephrotoxicity in the form of reduced GFR. And other problems are type 2 diabetic mellitus and systemic hypertension. These are the acute precipitant which lead on to chronic lithium toxicity, and here patient have water restriction by patient lead to hypovolemia. She had an vomiting which lead on to hypovolemia, and during the course of the dizziness, he had a head injury followed by which treated with the suture and managed with some painkiller. So which leads on to which lead on to acute and chronic presentation. This is a clinical manifestation based on lithium concentration on 1 milliequivalent per liter mild tremor, on 1.5 post tremor, and 2.1 hyperreflexia, and 2.5 milliequivalent per ataxia and confusion, and 3 milliequivalent per liter we have seizure and coma. This is approach to the lithium toxicity, and the patient can present with either acute and chronicity with present with nausea, vomiting, and diarrhea, and chronic poisoning present with like neurological manifestation like ataxia and confusion. Severe toxicity cause seizure and encephalopathy. The older patient at risk of toxicity due to hypovolemia or decline kidney function. The history examination is mainly focused on what is the dosage of drug, and it is accidental or intentional. The history suggests you of like volume depletion, vomiting, diarrhea, and fever and diabetes, which lead on to acute and chronic presentation. And we look after hydration status, and CNS examination look for sensorium and ataxia and tremor. Investigation in a patient with a suspected lithium toxicity to lithium concentration, electrolyte, creatine and urea, and TSH and ECG. The management initially this airway and breathing, and main goal is restore the sodium and water balance. The initially is managed with IV fluids with isotonic saline until euvolemic. The monitor serum sodium closely 4 to 6 hours, mainly patient with the nephrogenic diabetes insipidus. When to consider hemodialysis in the patients of chronic lithium toxicity. The symptoms of severe lithium toxicity are a serum lithium concentration is more than milliequivalent per liter with impaired kidney function, and serum lithium is more than 5 milliequivalent per liter. And there is a role of bowel irrigation also in patient in view of awake patient, asymptomatic patient, or intubated patient, or if the patient present within 4 hours or after ingestion of more than 10 to 15 tablets of lithium. This is acute management. Lithium toxicities defined as there is a history of intentional lithium ingestion or serum lithium concentration more than milliequivalent per liter with no symptoms, or with the symptoms, the serum concentration more than 1.2. Following symptoms are like tremor, fasciculation, vomiting, diarrhea. Severe lithium toxicities like seizure, encephalopathy, rigidity, hypertonicity, myoclonus, and cardiopulmonary collapse and life-threatening dysarthria. The initial care supportive will be mainly IV fluids with isotonic saline, and So based on the time of presentation actually. The patient present with 4 hours of injection or within 1 hour of large injection of intermediate release lithium, we can go for bowel irrigation with the polyethylene glycol. If it is no, we can go for hemodialysis. This is anion gap in lithium toxicity. In lithium toxicity, there is an increased level of lithium. So normally anion gap will be cation minus anion. In this, there is a more large quantity of lithium. So the anion gap in this patient was 3 and serum lithium concentration was 3.28. So anion gap minus lithium concentration will be minus 2.8. So negative anion gap in case of lithium toxicity. So finally, the Ms. S was started on adrenal infusion, followed by transcutaneous phasing in the ED and admitted to the ICU. She underwent an emergency hemodialysis and she is clinically improved. Lithium levels are declined. She developed features of urgent vasopressin resistance and managed with the IV fluids and then a low solid diet. Bradycardia.
What would you advise call this AVP resistance? What's it more commonly known as?
Diabetic insipidus.
What type? What type?
Diabetic.
You're correct. There are 2 types. Nephrogenic.
Nephrogenic. Bradycardia recurred after a week and discharge bill and reviewed on. So take home message is, and there is risk factor, precipitant and diagnosis of chronic and acute lithium toxicity and acute management of lithium toxicity, air breathing and circulation, volume repletion, and the role of GA decontamination, the role of hemodialysis.
Any questions? You've had an overdose of lithium toxicity in this meeting. You have two cases. So you must be experts in that by now. Any more questions on this? I think many of you missed the first case, probably.
I want to tell about this ladies. When we were making the presentation, we figured that the second OPD review, her sodium had actually gone up again to 145. So the nephrogenic PI of lithium can be irreversible and long-standing, even though she didn't come with hypernatremia. So we might have to.
So did she have polyuria? That's a question. That's an important point. How many liters was she passing?
Also in the OPD, I don't know. In the hospital, she was passing 6-7 liters of urine.
That is an important point to be highlighted, because see, intake output, what you realize when you are admitted is that it may not be necessarily accurate. Nurse comes and asks you every few hours, how much did you drink? How much did you pass? So unless you are one of those obsessive types who every time you pass, you pee into that measuring cup and write down. Actually, when my son was admitted, I took an intake output chart from the nursing station. I was writing on that. Otherwise, it may not be accurate at all.
She had a catheter because she just been
catheter it will be accurate. That's an important point that she was passing 6-7 liters a day. That needs to be highlighted. Immediately, it's diabetes insipidus. It's interesting that she was not hypernatremic. Normally, they become hypernatremic.
Hypernatremic during the hospital stay.
So, was it actually nocturia or was it polyuria that she was having when she came in? Polyuria. Okay, thank you. Very interesting. Thanks for inviting me for the clinical meeting. We'll close for today. Is it connected to Mission Hospitals?
Yeah, the link is sent out. They can also go to.
Do they ask questions? Not much, huh?
That's right.
You want to give back my gift?
Yes. Anyone?
He got it for answering the quiz first.